A lot of data come out this year about the next generation sequencing, and I think that the data at this point is still inconclusive about where it actually falls. I think that we have there are sites that don't have good pathology. So in a site that has very, very good pathology, I think what we can see is that it's not necessarily going to change our clinical care over a good pathologist who can tell us all of the already predefined, known poor risk markers. I think there's always a concern that there may be sites that don't have really a good thyroid cancer pathologist, and whether or not next-gen sequencing could help identify certain types of patients who might be at higher risk, who maybe you would change the paradigm a little bit. It still hasn't been proven, and I think that we'll probably end up in a situation like we have in breast cancer with some of the Oncotype DX, where you'll end up narrowing it down to a certain subgroup of patients who really might benefit, but it will really be the minority of patients, because the vast majority of patients, I think their care is already very well clear from their pathology, and I don't think that takes a lot of additional molecular studies. Now, where I do think it's already starting to play a role will be in the advanced setting, because we do have patients where we have identified BRAF mutations, and then they were eligible for the vemurafenib trial, which was clearly an active agent. And then there's another BRAF inhibitor from Novartis that we're going to be studying as well. So I think that there are going to be other BRAF inhibitors as well as other inhibitors that target specific mutations. So I think in the advanced setting, clearly a role. And I think there'll be more and more of a role as more of these trials are available. In the early setting, I think the jury's still out as to how we're exactly going to apply it. And even once that population is defined, remember, we still need a clinical trial to prove that that molecular testing is actually improving the outcome of those patients. Because we can test all we want, but unless we actually prove that we can create a treatment paradigm, follow it, and improve the outcome for patients, we won't really be doing anyone any good, and we'll be doing a lot of unnecessary molecular testing.